So let's go to some questions that have come in from our participants. How important is drinking water and walking after that procedure? Dr. Lotan, do you want to provide some comments? You mentioned that earlier. And do they do anything to rinse out the bladder once you've done all of the tumor removal to get that part out? Or, you know,
well, for sure, we're going to remove all the cancer that's floating around there as best as we can, and we use sterile water or glycine, which lyses cells, which is hypotonic. But we'll definitely irrigate all the floating things. It's one of the rationales for putting chemotherapy wash in the bladder to kill any cells that are floating. That's been shown to be useful in some patients. But if you have a large raw surface area, we don't want you to absorb the chemotherapy. And certainly if there's concern that you may have made a small hole in the bladder. So it's not something that's used every single time. But just in general, yes, after anesthesia, when you get home, we definitely want you to drink plenty of fluid so that you make a lot of urine, so that if you are having some slight oozing from the raw area, you don't form clots. The worst case scenario is if you're not making much urine and your bladder, and if you have some oozing, then you might form some clots. And we'd rather you wash out, the bladder gets washed out. As far as walking, I think it's good to stay active. We don't want you lying in bed so you don't form clots or get pneumonia or something strange like that. I wouldn't walk a marathon the next day. I think it's certainly good to get out of, to be up and about. But again, I would say avoiding strenuous activities. And if you normally walk 5 miles, I'd say 1 would be enough the next day and build back up.
So Ron and Lori, how about you as far as getting back up to your normal activity levels post procedures when you've had a TURBT? Mm-hmm. Did you jump right back into life as usual when everything kind of settled down, or how did you deal with that?
I think I spent 48 hours or so at home, and or just walking in the neighborhood. And after that, just, going out for dinner is fine, and going out for a longer walk is fine. I love to play golf, but I wait about 6 or 7 days before I do that. And okay. Within a week, I'm back to normal, and within a week, I think every time I've had a procedure, within a week the bleeding is gone. So I really feel pretty normal after a week.
Good. And how about you, Lori?
Yeah, as soon as I still had the catheter, no, nothing was normal. It was very uncomfortable. But once the catheter came out, which was like 2 days later, I felt pretty good. I didn't have cramping or fatigue or bleeding, and right. That was a big relief. So yeah, I definitely second the drinking water and moving around, to the extent that you feel up to it. But yeah, the recovery was not difficult.
Okay, great. Thank you so much. Here's another question from our participants. Why do they not send the entire tumor to the pathologist? I understand that it cannot be removed in one piece. When determining mixed grade tumors, how would a pathologist determine the percentage of high grade versus low grade to determine the overall grade if they don't have the entire tumor to analyze?
We do.
Well, we send the entire tumor. It's just we send it in pieces because if you have a large tumor, it's deceptive because on the resectoscope when you look, you see the entire screen, but the tube is not that wide. You wouldn't be able to fit a tumor more than 2 centimeters anyway, even if you tried through the urethra or through the resectoscope. So you do have to cut into smaller pieces, but we send every piece to the pathologist. Now, in terms of the question, if 50% of it's high grade and 50% is low grade, you don't have a low grade tumor. You have a high grade tumor because your cancer will behave similar to the most aggressive aspect of it. If you have 4 tumors and 3 of them are low grade and 1 of them is an invasive high grade cancer, we don't consider you as a mixed tumor. You have an invasive high grade cancer. You just happen to also have some low grade or some non-invasive component. So for us, it's not important the percentages. Now, I do rarely see some patients with focal high grade and a background of low grade, and that sometimes does impact my decision on what to do. But the pathologist will tell me that. They'll say, almost every piece I saw was low grade, and I saw a small area that I think is high grade, and I will treat that patient a little differently. But there's nothing that I don't take anything home with me. It's all going to the pathologist, and they're going to look at all of it.
Okay, well, that's good to know. I'm very happy to hear that. So can you talk a little bit about enhanced cystoscopy, whether it's with the blue light, with CysView, or narrowband imaging? What's the difference from your perspective, and is that better if it's available to a patient? Is it going to allow the doctor to do a better job? What is the story behind that?
Right. So normally when I give a talk, I have disclosures page. So I will give you a disclosure that I do consult with PhotoCure, which is a company that makes blue light. And I have done research with Storz, which is the company that makes the blue light scope. That aside, though, there are many randomized trials where half the people just got white light, half got white light plus the blue light, and found that the blue light improves detection of cancer, especially a flat tumor called carcinoma in situ, but also improved the ability to find additional tumors. In fact, the American Urologic Association guidelines actually recommends that if you can get blue light, or as a urologist, if you have it available, that you should use it because it does improve detection and reduce recurrence rates for patients. And the reason it reduces recurrence rate makes quite sense. If you had 3 tumors and they only found 2, then the other tumor is not going to go away on its own. You're just going to find it later, and then that's going to be considered a recurrence. But it really truly wasn't a recurrence. It was always there in the first place. And if you had removed it at the initial TURBT, you won't have to remove it at a subsequent TURBT. Now, biologically speaking, the way CysView works and blue light is CysView is a substance that gets taken up more often by cancer cells than normal cells. So when you shine a blue light, the cancer cells look pink. Narrowband imaging is actually incorporated with different scopes, and what it does is actually highlights blood vessels. And since cancers attract blood vessels, it's easier your eye would naturally go to the area with more blood vessels, so you'll see additional tumors. It's actually also recommended in the guidelines. This has a little bit lower level of evidence because the studies that were done didn't show quite as much of a difference. But obviously, if you have a scope that has narrowband imaging, it's actually made by Olympus, then you can do that. And I do it periodically in my clinic as well. But the vast majority of TURBTs in the US are done without either blue light or narrowband imaging. But if you have it available, then I think it does help in some cases, not in every case, but in some cases it does add value.
Great, thank you. I have another question, a little more of a technical question. What are the indications for fulguration versus excisional biopsy and pathological examination? What you talked about with the wire was the fulguration, correct?
Well, fulguration just means you're burning something.
Okay.
We sometimes will take patients with, especially in the office setting, where a patient, for example, may have 8 small tumors, and they always only have low-grade cancer. So you already know that they're a person who usually makes low-grade cancers. And patients who have recurrent low-grade cancers, less than 5% of them will have high-grade cancer. So if you have a patient who's got multiple small tumors, I might biopsy 1 or 2 of them, but I won't biopsy 8 of them because that will just lead to more bleeding and discomfort for the patient. So I can actually just burn the other ones, knowing that probably if they've always had low-grade, they probably still have low-grade. So fulguration literally just means burning a tumor. We sometimes do it in the operating room too. If you have a patch of tissue that looks abnormal, you might biopsy it, but you may not resect or cut out the whole patch because you don't want to have as big a raw area, as much bleeding, as much discomfort. So you might just biopsy part of it and burn the rest of it, and that's called fulguration.
So when you're looking for a physician to do this level of examination, can a general urologist, I'm sure they could do this. Is it better to go to a general urologist or to somebody who's really been doing a number of these procedures over the long term?
So there are 80,000 cases a year diagnosed with new bladder cancer, and there are about 500,000 people in the US living with bladder cancer. So as much as Dr. Smith and I like taking care of patients, there aren't enough academic urologists to do every TURBT in this country. Do I think there's a value in doing it repeatedly or having experience? Well, I'd like to think that experience helps with any procedure you do, but it's such a common procedure that people in training probably do a large number of them, and so most urologists would feel comfortable doing it. The truth is that both Dr. Smith and I see patients who have larger tumors or multiple tumors or some complexity that the urologist didn't feel comfortable doing the procedure, in which case they do refer them to us because they think that we would, have an easier time. I don't know that we have an easier time. It's just we don't really have other people to send it to, so we end up doing them. But at the end of the day, for straightforward TURBTs, the vast majority of urologists in the country should be more than capable of doing them.
Okay, excellent. Hold on, let's see. The pathology report on this individual's last TURBT stated muscularis propria present, but it was not the same report on their first procedure. What does that mean? Does that mean that they got a deeper sample the second time?
Yes. In general, we would like to see that the muscle is present and not involved in the majority of patients. Now, the truth is that because we cannot see, we see what we think are muscle fibers, but that doesn't mean that we get enough muscle fibers that the pathologist feels comfortable saying that there's muscle. Or that when we cut through with a loop that has electricity, it causes charring that the pathologist has a hard time saying that there is muscle. Now, bladder cancer does not skip through layers. So if it's not going into the lamina propria, which is the layer under the lining, then it's not going to suddenly show up in the muscle typically. So if you have a non-invasive tumor that's not going into the lamina propria and there's no muscle, then we don't necessarily feel like, oh, we've got to go back and get more tissue. But if it's going into the lamina propria and we didn't get muscle, then we usually want to go back and try to get muscle. Are we successful 100% of the time? No. We don't necessarily like to go a third time. So we really try to get that tissue if we can. But it's not always so easy because, like I said, visually, it's not like a Neapolitan ice cream where part of it's vanilla and part of it's strawberry and chocolate. And then you go, oh, I'm in the right layer. I did a good job. So we do our best to try to get where, the kind of tissue we need. Again, we are a little concerned because we don't want to make a hole and then have cancer cells spill out, and you need a catheter in for 7 to 10 days to let the bladder heal. So that's the challenge.
Another question from a participant. This person had 2 emergency fulgurations after having their TURBT because clots had prevented him from urinating. How common is that?
Thankfully, not very common. A little more common on patients who are on blood thinners because at some point they have to resume blood thinners, and many patients are taking aspirin or Plavix or Coumadin or any of a variety of these blood thinners because our patients are getting older and have heart disease or have a risk for stroke, and their primary care physicians like to put them on these blood thinners, and so that is a risk. Is it common? No, it's not common, thankfully. But if you do enough TURBTs, you're certainly going to have some patients who are going to have bleeding, and sometimes it'll stop on its own, and rarely we have to go back to the operating room and cauterize some vessel that we didn't see or that wasn't bleeding at the time of surgery.
Mm-hmm. Okay. I'm going to go back to the video for a minute. what the tumor looked like on that video was very large. And, what's the size of the wire, the little moon that you were talking about?
Oh, our loop.
Was that a typical size tumor? Was that a large tumor? People were
That
wondering.
would be a medium tumor. We don't really have a ruler. Yes, that loop probably is, and Dr. Smith might correct me. I think it's about 5 millimeters or something. So this tumor is probably, the nice thing about it was it's not a perfect sphere. So yeah, it's maybe 3.5 centimeters, 1.5 inches in diameter, but I've seen them when they're much bigger volume. We've seen tumors over 5 centimeters, which is what we would consider large. This would not be considered large. And sometimes it's a bit of a misnomer. The whole video is about 5.5 minutes, and that's basically how long I'm scraping from start to finish. Sometimes patients, well, it's an hour procedure, but some of it's going to sleep and getting positioned and all that. Now, I have scraped for 30 or 45 minutes and get a little workout. It's rare for me to be doing, for us to have to resect for more than an hour. That would be unusual.
Right. Well, that was a very obvious tumor because you could see all the little papillary things kind of swaying in the fluid. What do you do under somebody who's got a carcinoma in situ, so a flat tumor? How much more challenging is that from your perspective and also from the patient's recovery?
Well, first of all, there are two issues. I would not do carcinoma in situ patient without blue light. That was a white light, not blue light. I have many blue light videos. I picked this one specifically just because I thought it was kind of a nice view of a typical TURBT. But for carcinoma in situ, a blue light is, for me, sort of a must, so I can see where the cancer is. Otherwise, you just don't know what you're doing or where you're doing it. Now, carcinoma in situ is also a strange cancer in the sense that we don't necessarily think we're going to be able to resect all of it, and we depend on BCG or other treatments to help eradicate all the cancer. I will sometimes, if it's a reasonably sized patch, take several biopsies and then burn the rest of it because I know it's not invasive by definition. Carcinoma in situ is not. But if it's like occupying a third of the bladder, I'm not going to burn a third of the bladder. There's no point to it. I'll biopsy several areas to get the diagnosis, and then I rely on BCG to get rid of the rest, which actually I'm relying on the immune system to get rid of the rest. I'm going to use BCG to attract the immune system to the bladder to fight the carcinoma in situ.
Okay, great. Thank you so much. In a follow-up to TURBT, is it possible that the cautery effect, the scarring that comes from previous TURBTs could be mistaken for cancer cells? Or obviously you're very expert in doing this, so you know what you're looking at, but from a regular urologist who might only do 1 or 2 of these a year or 3 or 4, would they know the difference between potential scar tissue and another possible tumor?
So generally speaking, my eyes are not that much better than any other urologist's eyes. But if you're going back after 4 to 6 weeks, it actually kind of looks like a volcano. The center where you resected looks kind of charred, and then the surrounding area looks red, and the edematous kind of like it's just kind of swollen. The tissue is just healing. If you come back three months later, it's going to be flat and look white without blood vessels to it, and it's actually kind of, it almost has like a star pattern. So it depends on the timing. So if we go back because we didn't get muscle or because there were signs of invasion, we want to make sure there's no residual cancer, we're basically trying to get some biopsies of the floor where we resected and some of the tissue surrounding it. But I can't tell what's cancer. I can't tell what's inflammation. It just kind of looks red and angry to me. And there's nothing special about my experience that allows me to distinguish that. And in fact, if you use blue light, sometimes that will light up too, and what we call a false positive, because inflammation can sometimes take up this cis view as well. If you come back 3 months later, then if it looks just like a flat area with scar, then I think most urologists can say, okay, it looks like a flat the timing is really important in terms of what it appears like. But in general, you can distinguish, you know, if you come back a year later, you may not be able to tell at all where anything happened. And so because the lining healed nicely and things like that, sometimes you can see, but you can't always see. So a lot of it has to do with the timing more than the experience of the urologist.
Okay, I think we probably have time for one or two more questions. If you have multiple tumors that are clustered close to each other, are they measured together as one or individually? And I know what we just saw was showing how you have that wire and it's only going to scrape out a certain width of tumor. So you're not going to get all of those particular things at one time. So do you make a best guess when you're reporting on the tumor size to a patient? If there's a lot of tumors clustered together, do you just call it one, or do you say we have multiple tumors in a small area?
In fairness, it doesn't really matter, because for us, for something a patient doesn't care, for billing purposes, it matters what surface area, and then you could add it together or you could not add it together. Let's say you had two tumors that were 1.5 centimeters. If you put them together, it's 3 centimeters. If you count them separately, it's a multifocal tumor. It ends up in the same risk category for us one way or another. So it's just semantics. It doesn't change sort of what we do for the most part. I suppose to me, if there's a bridge of normal mucosa, I might consider it 2 tumors. I'm probably going to burn that little bridge because I'm going to worry that those cells microscopically may be abnormal anyway. So I'm not going to like just leave a small little segment of normal lining or normal appearing lining. I'll just take care of all of it just because that little piece of lining is not going to help the patient anyway. And I worry them leaving cancer behind.
Thank you. One more quick question. Do you ever end up removing a tumor that the pathology report says it's benign growth? Does that ever happen?
Yes. I mean, it happens more after BCG. You see a red area. I try to do more of these biopsies in clinic when I'm uncertain. And if it's a relatively small thing, I mean, what you saw today will never be a false positive. That's always going to be cancer. It's very typical. It's more often in patients, like you said, with carcinoma in situ, or patients who've had BCG that have like a red patch, which is not that uncommon. I usually will not take patients to the operating room and do resections. I usually will biopsy them in clinic. And if it turns out to be, and then I can cauterize them as well. If it turns out to be cancer and I felt like I didn't do an adequate job getting rid of all of it, then I might say, well, I'm going to biopsy these 2 areas. And if it turns out it's cancer, we might still go to the operating room. But for the most part, it's not going to happen for a papillary or coral looking thing. It's going to happen because somebody has something that looks atypical. And in order to avoid anesthesia, that's why I'll do an office biopsy in many cases, and then only go to the operating room if I'm worried that there's still a significant amount of residual cancer.
Right. So any tumor looking material can be removed with the TURBT, and then it's analyzed to determine exactly what it all is. Because I know we had somebody asking about a particular type of tumor, but are all tumors that are in the bladder removed with that TURBT?
Yeah, I mean, those are our tools. If you have, I mean, I've removed melanoma from the bladder or adenocarcinoma or squamous cell. I mean, other types of tumors. There are some benign things that you'll find as well, I suppose, that are very rare. But if you do enough of these, you'll find some rare things as well. But in general, it's the same type of procedure.
Well, thank you. This has been an incredibly informative program. I appreciate Dr. Lotan, you're spending the time, Dr. Smith, for giving us all of the information that we used in these slides earlier. Thank you so much. And Lori and Ron, thank you so much for sharing your stories. It really is helpful to understand what that lived experience really is. And do you have any parting words before we end today's program? Lori?
No, I just, I appreciate the opportunity to participate and share my experience and anyone who I can help on this journey, I'm very happy to be able to do that. So thank you again for inviting me.
Thank you. Ron, any comments to add?
I think follow-up is the most important thing I've learned, you know, in being a cancer patient, bladder cancer patient. You can't ignore it, and it can keep popping up, and you have to keep up with your visits.
Well, as a lot of people have said, you know, when you have bladder cancer, you form a long-term relationship with your urologist, especially with the non-muscle invasive, because it does have this ability to come back. So Dr. Lotan, thank you so much for everything that you've done to get this program together. It's been very informative. We appreciate everything. I want to remind everyone that we will be sending you a short survey so that you can give us a little bit of feedback. That's always very helpful, and we use that to plan future programs. And today's program, again, was co-sponsored by the Cystobladder Cancer Study. So Dr. Smith and Lori, because you're on the advisory board for that, thank you so much.
Thanks for inviting me.
Take care. We're going to end today's program.
Bye-bye.
Bye-bye.